for being here. Let me thank Senator Collins and her staff for helping us put together this hearing on an issue that I consider to be enormously important. Let me thank our panelists. Two of them are here with us, and two of them we see you clearly through modern technology. Thank you all for being here. We look forward to your testimony. It is no secret that our country faces many healthcare crises. Too many of our people are uninsured or underinsured. We pay by far the highest cost for healthcare of any major country on earth. Cost of prescription drugs are off the wall, and many people can't afford that. And in the midst of all of that, for whatever reason, and I think we'll delve into that today, our nation, the richest country in the history of the world, simply does not have enough doctors, nurses, dentists, and other medical professionals. And why that is so, I'm not sure, but I hope we can learn something about that. But the result is that according to the Association of American Medical Colleges, by 2033, the United States will have a shortage of up to 139,000 physicians. And primary care physicians, and we already have a crisis in terms of access to primary care for many people throughout this country. Primary care alone will be facing a shortage of up to 55,000 physicians. And by the way, as we all know, this does not take into account what COVID-19 has done to the health profession. Anecdotally, I have heard from hospitals, many nurses just exhausted, leaving the profession. Hundreds and hundreds of medical professionals have died as heroes and heroines fighting COVID-19 and protecting the American people. But no question that healthcare professionals have taken a very big hit as a result of COVID-19. The federal government, as we all know, plays an enormously important role in how many physicians we have, because through the Medicare Graduate Medical Education Program, we fund the vast majority of residency slots in this country. In 2015, the most recent data available indicates we spent about $16 billion on graduate medical education, providing for roughly 31,000 residency slots a year. Last year, Congress added 1,000 additional slots. That's a step forward, but it is nowhere near enough, I think, to address the crisis that we face. Very importantly, I think, maybe we can discuss this a little bit today, in addition to expanding those slots, Congress did expand the Teaching Health Center Graduate Medical Education Program. And that is a much smaller program than what Medicare does, but it focuses directly on the needs to get doctors and others into medically underserved areas. Very shortly, I will be introducing legislation to address the multiple crises we face, and I just want to very briefly touch on what that legislation will do. Number one, and I hope some of our panelists will speak to this issue as well. I learned, Senator Collins, recently, calling up New England medical schools, as a matter of fact, that the number of medical students per class is a lot smaller than you would think. For example, if you look at Dartmouth or UVM Medical School, we're talking about 90 or 100 students per class. Now, I know that it's an intensive effort to train a doctor, but I would think maybe we want to explore whether we can produce more doctors through larger medical school classes. 90 or 100 per class seems a little bit small to me. Clearly, we also, and there's, I think, widespread bipartisan support for the understanding that we need to increase payments for direct graduate medical education. The legislation that I will be introducing picks up on work being done by Senators Schumer, Bozeman, Menendez, and others, would authorize 14,000 new Medicare-supported medical residency programs, positions over 7 years, 2,000 a year, in addition to what we have. Further, and very importantly, what our legislation would do is to establish new criteria for how the new GME training positions would be allotted to qualifying hospitals, with a minimum of 50% of new slots going toward primary care. In other words, the crisis we face is not only a shortage of doctors, is where those doctors are. They're not in rural Maine. They're not in rural Kansas. And they're not in rural Vermont. We have a hard time attracting them. We do not necessarily need more dermatologists on Park Avenue in New York City. I don't know if we do or not. Probably not. But we do need them in rural areas all over the country. And we have to make sure that Medicare understands that. Another issue that maybe panelists can pick up on, I think we all know that residents are really underpaid. You go 4 years to medical school, you do a year of internship, and the average pay for a resident is $63,000 a year. So you got medical debt, right? You got a few $100,000 of debt. Oh, is that right? But costs have gone up a little bit too. Yeah. But if you're living in a big city, you were making $20,000 and working long hours, I expect. Yeah. All right. Well, that's another story. But here's one thing that gets to me. While the average resident earns $63,000, which I think is inadequate, primary care residents earn $58,000. So the discrimination starts right there in the residency program, not to mention what salaries are paid. Doesn't make a whole lot of sense to me. I think we should increase, and our bill will significantly increase funding for the Teaching Health Center Graduate Medical Education Program. We have made progress. I'm happy to say that in the American Rescue Plan, some of us worked very hard to double funding for community health centers and triple funding for the National Health Service Corps. And I think we have to continue that effort. So that says to somebody, if you're going to be graduating medical school $300,000 in debt, you ain't going to rural Maine, frankly. All right? And we're going to help you pay off that debt if you do go to rural Maine or rural Vermont or rural any place. So that's some of my thoughts, and I look forward to this serious discussion. Senator Collins.
Mr. Chairman, thank you so much for holding this very important hearing today. Our country is tremendously grateful to the medical community for its colossal efforts during the past year. Many healthcare professionals are exhausted by the physical and emotional toll of caring for COVID patients. And that burden, I think it's important to note, did not fall solely on the medical workers themselves, but also on many members of their families who have had to cope with separation, long hours, health risks, and stress from closed schools. In many areas of the country, there is a fierce competition for nurses, nursing assistants, other medical professionals, and physicians. And as the chairman has mentioned, for those of us who represent rural states, the competition is particularly stiff. The situation is particularly acute in our nursing homes, where low Medicaid reimbursement levels often translate into low wages. This workforce shortage has been with us long before COVID. It is frustrating to watch year after year tens of thousands of qualified nursing school applicants who are turned away each year due to a lack of a sufficient number of faculty and a shortage of clinical sites. We need to break that cycle at a time when our nation is aging and as more and more people are living longer with increasing health needs. These shortages have serious consequences. Growing up in northern Maine, I know the vital role that nurse practitioners and physician assistants in particular play in our healthcare system in rural areas. That is why one of my highest priorities in the Senate has always been to increase funding for workforce programs. The bipartisan work that the Health Committee has accomplished to support healthcare workforce training has made a difference. Both the Title 7, health professions training and the Title VIII nursing workforce programs were reauthorized by the CARES Act last year. We need to make sure that they're sufficiently funded. While many health professions desperately need to attract more students, several disciplines stand out. One is addiction medicine, a theme that we heard in the excellent committee hearing on mental health last month. In March, researchers from Stanford University wrote in the Journal of the American Medical Association Psychiatry that opioid overdoses likely reached a record high in 2020 because COVID has exacerbated stress and social isolation and interfered with opioid treatment, addiction treatment. That is certainly true in the state of Maine. Last year, a record 502 Mainers died from overdoses, a tragic toll that exceeded even the deaths caused by COVID-19. Senator Hassan and I recently reintroduced the Opioid Workforce Act, legislation that would create 1,000 new medical residency positions focused on addiction medicine at teaching hospitals. And we're grateful to the American Association of Medical Colleges, which is represented here today, for its endorsement of our legislation. Another area of unmet need is geriatric medicine. In Maine, there are more than 250,000 Mainers who are over the age of 65, and we only have 40 geriatricians. There is an acute need to quickly train more geriatric health professionals and direct service workers to meet the growing demand. And I agree with the chairman that we need to provide incentives to get them into rural areas through partial forgiveness of their medical school debts. Last year, the CARES Act included my legislation with Senator Casey to formally establish and authorize funding for the Geriatrics Workforce Enhancement Program, the only federal program designed to increase the number of healthcare professionals with the training to care for older people. Today, there are 48 geriatrics workforce enhancement programs in 35 states, including a terrific program at the University of New England, and I'm very pleased that UNE's president, Dr. James Herbert, is testifying today. Increasing the overall number of healthcare professionals is just part of the shortage equation. Another, as I've mentioned, is making sure that they practice in communities across the country, including in rural areas. And one way we can do that is expanding where medical residents train. The December Omnibus Appropriations Bill contained a 3-year authorization of Teaching Health Centers Graduate Medical Education Program, a program that I've championed with Senator Tester. Teaching Health Centers train medical residents in community-based settings, including low-income, underserved rural and urban neighborhoods. Why does this matter? It matters because we know that people are much more likely to stay where they train. And if we can get people out to underserved areas to do their residencies, they are much more likely to practice there. I know that I could go on and on. Let me just end by saying that I think telehealth is another avenue to address the mismatch in supply and demand, particularly in behavioral health. The determination and compassion that leads students to choose a career in healthcare are needed now more than ever. I very much appreciate this hearing, and I look forward to hearing from our excellent witnesses. Thank you, Mr. Chairman.
Well, thank you, Senator Collins. This does appear to be an issue where there may be a bipartisan approach to a very serious problem. We have a great panel, and let me begin with Dr. David Scorton. Dr. Scorton is the president and CEO of the Association of American Medical Colleges, which represents the nation's medical schools, teaching hospitals, and health systems, and academic societies. Dr. Scorton, thanks so much for being with us.
Thank you, Chairman Sanders and Ranking Member Collins, for holding this hearing. I'm honored to be included among this distinguished panel, and I look forward to discussing challenges related to the physician workforce. I'm proud to represent academic physicians who daily teach our next generation of doctors, perform life-saving research and care for some of the nation's most vulnerable and complex patients. In just one example, years of federally funded research led to the scientific underpinnings for the mRNA COVID-19 vaccines that are now saving so many lives. Addressing the nation's physician workforce shortages and related challenges will require a multi-pronged public-private approach, including innovations such as team-based care and better use of technology, in addition to increasing the overall number of physicians. Our annual workforce report continues to project that demand for physicians will outstrip supply, leading, as the chairman mentioned, to a projected total physician shortage between 54,100 and 139,000 physicians by 2033, including both primary care and non-primary care specialties. The range reflects a variety of scenarios that may affect the exact future needs, including population shifts, delivery pattern changes, and increased use of physician assistants and advanced practice registered nurses. The fact is, we have a current and projected shortage of physicians that is ominous and requires our best efforts and your support. Though our report focuses on physicians, I underscore the major contributions of other health professionals. Not surprisingly, the nation's growing aging population continues to be the main driver of increasing demand for physicians over the next 15 years, on top of current stressors, including behavioral health needs, substance use disorders, and of course, COVID-19. Our physician workforce also is aging, and a large proportion are nearing the traditional age of retirement, thus affecting supply, as do physician well-being and work-hour patterns. It can take more than a decade for a physician to complete medical school and residency training, also known as graduate medical education, or GME. This postgraduate training is required to become licensed for independent practice. U.S. medical schools have increased enrollment by 35% and opened 30 new schools since 2002. However, this growth will not increase the workforce without increasing residency training slots, which have not increased enough to address the shortage. The WMC has endorsed the Resident Physician Shortage Reduction Act that would raise the cap on Medicare support for GME and help train approximately 3,500 more physicians each year. We also believe that Children's Hospital and Teaching Health Center GME, as you've heard, are critical programs complementary to Medicare GME. We must also increase private and public efforts to help shape the primary care workforce, increase community-based training and rural practice, and improve workforce diversity. Many successful programs already exist at the Health Resources and Services Administration, but in our view, they need additional investment to increase their scope and reach. The WMC convenes the Health Professions and Nursing Education Coalition, which calls for a doubling of HRSA Title VII funding in fiscal '22. Furthermore, public service scholarship and loan repayment programs can be effective, targeted incentives for recruiting physicians to help specific vulnerable populations. And I thank you, Senator Sanders, for championing the recent historic investment in the National Health Service Corps. Intervention earlier in the education pipeline is necessary to increase the number of students from rural, underserved, low-income, minorities, and other disadvantaged backgrounds. The programs I've already mentioned will be more successful if we recruit students who are more likely to practice primary care in underserved communities, including those from diverse racial and ethnic backgrounds. I am very concerned there has been minimal progress in increasing physician workforce diversity. In 1980, when I began my first faculty appointment, Black men made up 3.4% of entering U.S. medical students. Today, Black males are 3.6% of all U.S. med students. It's inexcusable that we haven't moved the numbers in 40 years. Beyond the efforts of our nation's medical schools, I would encourage this committee to speak with families and students from kindergarten through college to better identify and address barriers so that we can work together to expose young people to science, particularly those who are currently underrepresented in medicine. I thank you again for the opportunity to testify. We stand ready to work with this committee, with Congress, and with my distinguished colleagues on this panel to improve the nation's healthcare workforce. Thank you very much.
Dr. Scorton, thank you very much. Our next witness is Dr. Leon Mcdougall. Dr. Mcdougall is the 121st President of the National Medical Association and the first African-American professor with tenure in the Ohio State University Department of Family Medicine. Dr. Mcdougall, thanks so much for being with us.
Hello. I want to thank the chair, Senator Bernie Sanders, and ranking member, Senator Susan Collins, and other members of the subcommittee for the opportunity to discuss the healthcare workforce crisis facing U.S. communities. The COVID-19 pandemic has served as a stress test for communities made vulnerable by racism, bias, geography, disability, and social economics. Improving social determinants of health, primary care access, and workforce diversity are central to any solutions that enable communities to overcome a failed stress test and barriers to health equity. We know that primary care access results in cost savings and improved health disparities and outcomes. Well, why is that? Primary care physicians take a person-focused as opposed to disease-focused approach to health care. Rural and urban populations with higher ratios of primary care physicians have lower rates of mortality for all causes. The supply of primary care physicians also improves disparities and health outcomes related to income inequality. In addition, after controlling for income inequality and socioeconomic characteristics, a higher supply of primary care physicians is associated with a 4 times greater lowering of total mortality among African Americans. In regards to specialty selection and healthcare access, we know that African American, Hispanic, Latino, and American Indian physicians are more likely to become primary care physicians and provide care in underserved communities. Ranked number 1, number 2, and number 3, Morehouse School of Medicine, Meharry Medical College, and Howard University College of Medicine have the highest social mission scores for medical schools. The combined composite, taking into account the percentage of graduates who practice primary care, work in health professional shortage areas, and who are underrepresented in medicine. So, proposed remedies. Yes, I'm in agreement with everyone here. Priority should be given to funding more primary care GME positions for hospitals within rural and urban health professional shortage areas or medically underserved areas. Yes, priority should also be given to funding more primary care GME positions for hospitals affiliated with medical schools with higher social mission scores. And in addition, I want to focus on a program that the National Medical Association and Association of American Medical Colleges have collaborated on. It's the Action Collaborative for Black Men in Medicine. And a recent study revealed that the percentage of Black men who were physicians has remained at about 2.6% for the past 80 years. So in closing, thank you for providing me the opportunity to offer my thoughts and suggestions to improve the healthcare crisis in this country so that all of our communities can benefit from accessible and empathetic healthcare. The National Medical Association stands ready to assist you in any way that we can to achieve this goal.
Well, Dr. Mcdougall, thanks very much for your comments. Now I'd like to welcome our next witness, Ms. Shelley Spires. Ms. Spires? Ms. Spires, we can't hear you. You're on mute.
So sorry.
Okay.
Good morning, Chairman Sanders, Ranking Member Collins, and members of the committee. Thank you for inviting me to speak to you today on this very important topic. I'm here today on behalf of the Association of Clinicians for the Underserved, known as the ACU, as a member of its board of directors. The ACU is a nonprofit transdisciplinary organization of clinicians, advocates, and healthcare organizations united in common mission to improve the health of America's underserved populations and to enhance the development and support of the healthcare clinicians serving these same populations. I'm the CEO for Albany Area Primary Healthcare in Albany, Georgia. We serve over 45,000 patients. Prior to serving as CEO, I spent most of my career in human resources, which has allowed me to have experience at delivering care to the underserved and recruiting and retaining the workforce to support these needs. Three things that I would like to talk about today that I feel like is a foundation to my experience is one, the people who do this work are committed, they are mission driven, and they are dedicated. The patients who receive the care, they're resilient, smart, and inspiring. Federal support for these people are critical and pays huge dividends. Let me give you a little more detail about each of these. Well, so I'll tell you about the people that are committed, mission driven, and dedicated. It makes more sense to kind of give you some ideas about the realities of working in an underserved population. Many patients live with chronic conditions, sometimes untreated and neglected. This makes for a more intense and long, ongoing complex of care given to this complexity of patients. High numbers of our patients are low income and living in poverty. 91% of health center patients are at or below 200% of the federal poverty level. Most of our patients are members of ethnic and racial minority groups. This supports the fact that culturally competent care is vital to effectively caring for their specific needs. Working in systems of high-quality patient-centered work surrounded by colleagues that share the same goals and mission has defined the Association of Clinicians for the Underserved. Being a board member, that's one of the things that drove me to providing a service under the board, based on the fact that we spearhead advocacy for the National Service Corps and support the workforce retention and recruitment efforts. The term burnout among healthcare providers was a huge topic prior to COVID. It didn't go away. Unfortunately, those new demands placed on providers as a result of the pandemic have only exacerbated the impact of burnout. And while burnout is important overall, with a real impact on staff retention, the other side of the human capital coin is recruitment. Recruiting staff to work in underserved areas is, in a word, tough. This goes for all staff, in particular focusing on clinical staff. The good news is we have existing programs that help with these challenges, but these systems could always have some additional investment. Among the programs that can always benefit from more investment that can provide a substantial return are your National Service Corps and your Nurse Corps programs. Since its inception in 1972, the NHSC has expanded not only in numbers of clinicians, but the types of clinicians, which shows we continue to adapt to the needs of the healthcare system, which is reflected in its workforce. While there are countless examples of the National Service Corps and what it's done for addressing the workforce shortages, it's vital to recognize that the health equity and health equality are key components of federal health policy. The NHSC is an important vehicle to achieve these goals by delivering services to our underserved areas and through the workforce that delivers these services. Ensuring greater racial and ethnic diversity of the healthcare workforce is essential for increasing access to culturally competent care for all of our nation's communities. Just to give a better context or a bigger picture, the latest data shows African Americans make up 6% of the U.S. physicians, 4.4% Hispanic and Latino. This data, in contrast to the core demographics, is 7.2% African Americans, 18.2% Hispanic and Latino. Unfortunately, historically, there's been insufficient funding to support all clinicians who are interested in the National Service Corps. In recent years, 10% were awarded the scholarship. 40% were awarded loan repayment programs. The result aided in not being able to fund applicants in some of America's most neediest communities. While the current field strength of the NHSC is greater than 16,000, serving more than 16 million people, there is still a shortage. Statistics indicate that nearly 33,000 additional clinicians across disciplines are needed to care for hundreds of millions of people who reside in these shortage areas. Another component is our THCs, our teaching health centers. They're located in community-based ambulatory care settings and serve a large number of Medicaid patients. It's been stated many times before, people who train in these underserved areas are likely to remain in practice in the same similar setting, remembering that residency often trains individuals and predicts the practice style regarding quality and cost. I would also like to call your attention to barriers to some of the other issues that we face in recruiting healthcare professionals, behavioral health. Most FQHCs and RHCs are not positioned financially to take on such large salaries. This salary is very hard to offset when you are serving underserved, uninsured, and underinsured population. These are the people in most need. I have had at least 4 psychiatrists interview and decline due to salary. The interest is there because of the mission of what we do, but the salary is the barrier. Colleagues across the country continue to collaborate on ideas how to share resources to meet these needs. I'd like to leave you with just a few concrete suggestions and actions for Congress. Increase funding for National Health Service Corps and Nurse Corps. We estimate total annual program costs for the NHSC to be $1.5 billion, taking into account existing funding, a minimum of $400 million in FY22. Annual appropriations is needed in order to address the need. Support the creation of state loan repayment and increase funding or reappropriate funding for teaching health centers. The NHSC program has proven time and time again to be an effective program. I appreciate the opportunity to testify before you today, and thank you for recognizing the urgent need that we face amongst our workforce.
Well, thank you very much, Ms. Spears. Senator Collins will introduce the next panelist.
Thank you, Mr. Chairman. I am delighted to introduce Dr. James Herbert of the University of New England, who is here to testify. He is the 6th president of the University of New England, and during his tenure, UNE has launched a Center for Excellence in Public Health, which has strengthened its partnership with external clinical partners and has built a health workforce pipeline to underserved areas in New England. He has a long and distinguished record. He is an internationally renowned psychologist who has done research into the treatment of mood and anxiety disorders and is a fellow of the Institute for Science in Medicine, the Association for Contextual Behavioral Science, and several other groups. I'm going to stop so that he can get to his testimony, but suffice it to say that we're delighted to have him leading UNE in the state of Maine and here with us today.
Thank you so much, Chairman Sanders and Ranking Member Collins. I appreciate the kind introduction. Just by way of context, the University of New England is Maine's largest private university. We have campuses in Biddeford and Portland, Maine, and in Tangier, Morocco. And we consider ourselves, although a private university, we very much have a public mission. As you probably know, Maine has the oldest population in the nation, and we're tied with Vermont as being the most rural state. We also have one of the oldest healthcare forces in the nation, and the challenges that we face in Maine are harbingers of what the rest of the country is not only facing, but will increasingly face as our nation ages and as urbanization creates pockets of need, not only in urban areas, but especially in our remote rural areas. I'd like to address 5 specific strategies that I believe can go a long way to addressing the healthcare workforce crisis. At the University of New England, we're trying to act on each of these 5 strategies, and I'd be happy to answer any questions or share any ideas about what we're trying to do. But let me hasten to add that I'm not suggesting that we have all the answers, that we figured it out. But what we have found is that the key to moving the needle forward, regardless of strategy, are strategic partnerships between higher education, government, business, and the nonprofit sector. So the first thing we need to do And Senator Sanders, you touched on this exactly, is we simply need to increase the number of healthcare professionals we train, including doctors. The single biggest challenge to doing that is the limited availability of clinical training opportunities, as you both have noted and as my fellow panelists have noted. As financial margins have tightened over the past 3 decades, practicing clinicians have less time to devote to clinical training. We must support partnerships between universities and healthcare systems to develop additional GME and other clinical training opportunities. Now, this isn't the only infrastructure limitation. Standing up new educational facilities or expanding existing ones involves significant startup costs. This is true both in the case of GME, but also in the case of expanding the size of medical schools. For example, at UNE right now, we're looking to expand the size of our medical school significantly, but that involves building new facilities.
How large is your medical school now?
165, and we're looking to go to 200 and then a little beyond 200. Another barrier is the difficulty in hiring and retaining qualified faculty members who can typically earn more in direct care clinical services than they can as university professors. Support such as that displayed by both of you, Senators Sanders and Collins, for strategic healthcare funding for faculty is vitally important to continuing those programs. The second thing we must do is we must train more healthcare students who look like the communities that they serve. It's well established that individuals from underrepresented groups are more likely to seek out practitioners who share their identities and backgrounds. Studies have found that minority patients who are treated by clinicians who look like them are more likely to use needed health services and less likely to delay care. Now, it's not enough, as you've both noted, it's not enough to merely train more professionals. We must encourage them to practice in underserved areas following graduation, especially in rural and tribal communities. Like Maine, most states have vast rural areas with highly distributed populations, and these communities have far less access to health care. Programs that provide financial support in terms of loan repayment programs, there's federal programs administered by HRSA, there's state programs, a new one in Maine. These kinds of programs are absolutely critical, and I thank you for your continued support of them. Fourth, we must leverage the power of technology to serve underserved communities. Digital health and emerging developments in telemedicine have enormous potential to transform healthcare delivery. Of course, these tools depend upon reliable and robust broadband systems, and I'm delighted that the most recent COVID-19 stimulus legislation included funding for broadband infrastructure. And finally, we must fundamentally change the prevailing educational model. Anyone who's recently been a patient in a hospital or has cared for a hospitalized loved one understands how siloed the practice of healthcare tends to be. In response, a new educational model has emerged in which students from diverse disciplines are explicitly trained to work together across traditional boundaries in multidisciplinary teams. This is known as interprofessional education, or IPE for short, and this model has been shown to improve clinical outcomes, to reduce medical errors, to increase patient satisfaction, and to decrease provider burnout. One particular area that highlights the importance of this kind of collaborative team-based approach is geriatrics. Diseases of aging often encompass a broad scope of conditions, heart disease and diabetes treated by primary care practitioners, isolation by social workers, oral health by dentists and hygienists, and so on. At UNE, we're weaving geriatric training throughout all of our healthcare professionals. So rather than just merely training more geriatricians, we're weaving training in geriatrics and in behavioral health across all of our healthcare professionals in this team-based approach. I'm pleased that working together with Maine's junior Senator Angus King and the University of Maine and other statewide partners, we're one of 48 organizations to have received funding through HRSA's Geriatric Workforce Education Program. In conclusion, successfully addressing America's healthcare workforce crisis will require not merely acting on each of these 5 strategies in isolation, but seamlessly integrating them. And strategic investment of resources will be required, but much of the work reflects cultural changes that will require strong leadership, a willingness to innovate, and coordinated partnership, again, between academia, government, industry, and the nonprofit sector. So I'm grateful for your time and happy to address any questions. Thank you very much.
Thank you very much, Dr. Herbert. I have been impressed that from the panelists and from the members here, I think there's a general consensus about what the crisis is and probably the direction that we have to go forward. I have about 400 questions, but I have time for 3 or 4. Let me start. Dr. Mcdougall made an interesting point, which we don't talk about enough, and I'd like each of you to tell me whether you think he's right. We are losing, as I understand it, 50, 60,000 people a year because they don't get to the doctor when they should. But interestingly enough, when you have more primary care physicians, it not only saves lives, it saves money as well. That's my impression. So you get to a doctor when you're sick, you don't end up in the hospital or the emergency room. Is that a true assertion that in the long run, giving people more access to primary health care not only keeps them healthier, probably saves the system more money? Let's go to everybody. Dr. Skorkin, you want to begin?
Thank you. Permit me 15 seconds to thank and congratulate the other panelists on their very important contributions, not only at the panel today, but in general. I agree with what you just said, Chairman, but I want to add one thing. Let me just give you my bona fides. I ran a general medicine division for 5 years at the University of Iowa, in which we were primary care provider as well as rural health provider. And so I could not be more simpatico with the importance of rural health and rural health care and changing the calculus. However, we need clinicians in specialty areas as well. And it's very, very important that we don't put those two things off sort of butting heads against each other. We need more of a variety of things. And so that's one thing that I would comment on. And then secondly, I would say that there's no question that primary care and preventive care go together, just as Dr. Mcdougall stated. I'll be very quick, Mr. Chairman. But I do want to say that depending on the issue, the idea of interprofessional teams are very, very important. So we have to think about things beyond the physician workforce. And so overall, we continue to hope that you will help to do things like the Residency Act, to have more GME slots in general, do the incentives to bring them to rural areas and primary care, but fill out all the areas that we
Sorry
need.
to be rude, but there's not a lot of time, and I want everybody to comment, and I have some other questions. Dr. Mcdougall, do you agree with yourself?
Yes, I do. And we spoke to geriatrics earlier. I'm a geriatrics physician by trade. Most of the patients I see are older. So using the skills that I developed and learned in residency and so forth have allowed me to serve in that role.
Okay. Ms. Spires.
Yes, sir. Thank you. I would certainly agree with that comment. I have seen it firsthand with patients who, if it hadn't been for the primary care physician and in a setting such as a federally qualified health center, potentially would not have received the care they needed. And the ongoing idea of the diagnosis would certainly lead to hospitalization. And so when you're looking at things such as chronic illnesses, which we face every day, which is if it's managed, will decrease expenses as it relates to Medicare, Medicaid, with putting people into the hospital. So when you're looking at a primary care physician who is the individual responsible for managing that chronic illness for that patient, it truly, if we do what we're supposed to do from our standpoint, it does truly decrease the cost from a bigger picture standpoint by being able to provide that care.
Okay. Dr. Herbert?
The answer is absolutely yes. There's no question. It's not even up for debate. There's research showing very clearly that those investments in primary care pay. I would add 2 quick things. One is primary care involves more than just family practitioners, doctors. It also involves psychiatry, OBGYN, which are desperately needed. The second thing I would mention are mid-level practitioners, so-called physician extenders, PAs, nurse practitioners. Those folks can be critical in meeting unmet needs in rural areas.
All right, Mike, I'm running out of time, but one quick question here, and I'd like all 4 of you to comment on it. Explain to me why, when primary care physicians often work so hard, crazy hours, why are they paid substantially less than other specialists? Does that make any sense at all? Dr. Skorkin?
It's going to be hard to answer that question briefly. It has
You
to,
got to do it briefly. I got 16 seconds here, very briefly.
okay, it has to do with the way our payment systems are set up, and it's not directly linked to the quality or the importance of care.
But it does say something about the system that primary care physicians receive substantially less than surgeons.
That's right.
Okay. Dr. Mcdougall?
We're not a procedure-based specialty. We're a person-focused specialty, and that doesn't necessarily lead to increased revenue, but an increased cost savings that doesn't necessarily reflect in pay.
Ms. Spears?
Absolutely. Yes, I think that they are certainly underpaid, not just from the standpoint of being a specialty service, but they actually take care of the entire person. I mean, you're looking at a holistic approach. And so they're managing multiple issues versus one dedicated issue.
Dr. Herbert?
Our payment system is based on procedure and visit codes. That's what you get paid for. If a primary care physician spends 50 minutes counseling a patient on their diet, lifestyle, exercise, this sort of thing, a patient with chronic disease, they're going to get paid less than if they'll get paid 1/10 to half what they would get paid if they did an EKG, maybe a catheterization, gave them some medications. It's the payment system is flawed and it incentivizes the wrong things.
Thanks very much. Senator Collins?
Thank you, Mr. Chairman. Dr. Herbert, U.S. nursing schools turned away more than 80,000 qualified applicants from baccalaureate and graduate nursing programs in 2019, and faculty shortages were cited as the top reason. So think about that, 80,000 qualified applicants who wanted to be either initial RNs or advanced practice nurses turned away because of a lack of faculty. How can Congress help with the faculty side of the equation that is creating this bottleneck and contributing to the shortages?
So thank you, Senator Collins, for the question. It is a challenge with nursing faculty in particular. I would say all of the faculty disciplines, it's a challenge, but nursing in particular. One of the things that many places, UNE being one, that we're doing is training our own now. So we're standing up a program to train nurse educators who in turn will become our own faculty because there's not enough nurse educators out there. The second thing, the loan repayment programs are absolutely critical. There are a number of programs out there. I know you've sponsored many of these, and I'm deeply grateful for that. I know right now that at least 4 of my nursing faculty are taking advantage of those programs, and these are individuals who would not have gone into nursing teaching were it not for those programs. And then fundamentally, a big challenge is that nurses can simply make more out in practice than we can pay them at universities. And of course, the easy answer would be, well, just pay them more, right? But I have to balance my budget, and I have to live within a balanced budget. And if I don't want to charge my students higher tuition or to decrease their financial aid, the institutional aid that we offer them, in order to pay them more. So therein lies the dilemma. So support on any one of those 3 initiatives would be phenomenal to help with this problem.
Thank you. I'm very intrigued that you're training your own educators. I think that's a very innovative idea. Dr. Mcdougall, it's really distressing to hear from you that the number of Black physicians has remained flat for, I think you said, 80 years. I held what I believe to have been the first hearing in the Senate to look at the racial disparities in the COVID cases. And even as a state with a small Black population like Maine, we see that disparity. I get a report on it each and every day from the Maine CDC. I had at that hearing Morehouse University testify about what could be done, and they echoed what was said here, that we need to be training more people who look like the community that they're serving. That's clearly true, and it would help overcome the legacy of mistrust between the Black population and medical professionals that exists in some areas. But how can we get more Black Americans, Hispanic Americans, Native Americans to apply to medical school and to see that as a career path?
Very good question. We need to go to our elementary schools, pre-K through 12th graders, and we have a program at The Ohio State University called Health Sciences Academies, where there's a cascading mentorship model involved with partnering with the teachers and parents of students who are feeder schools into Columbus East High School, which was right across the street from Ohio State East Hospital. I think those types of initiatives where we have that expertise at the academic health center in our 7 health professions colleges, and we partner with the elementary, middle, and high schools to create that pathway of opportunity. And I think that's one example, in addition to the existing HCOP programs and the other pathways funded through HRSA. Very good question. Thank you.
Thank you for an excellent answer. Thank you, Mr. Chairman.
Okay, thank you, Senator Collins. I have on my list Senator Braun, Senator Kane, Senator Hassan, Senator Baldwin. Senator Baldwin, are you there, Tammy?
I am.
Where are you? I don't see you.
I'm virtual.
All right. There you are.
Hello, Mr. Chairman. Thank you for the recognition. And I want to thank our panelists. What an important hearing. I wanted to focus in on the importance of training in the area of palliative and hospice care. Dr. Mcdougall, you just stated that you're not a procedure-based specialty, your area of practice in geriatrics. You're a person-based specialty. And I would argue that the same is true in palliative and hospice care. So one of the challenges in preparing health professionals for careers in palliative care is the lack of support for trained professionals to serve as faculty and dedicate time to the educational function. There's an urgent need to build our workforce, but we can't do it without building the workforce training infrastructure. I've introduced bipartisan legislation with my colleague, Senator Shelley Moore Capito, called the Palliative Care and Hospice Education and Training Act, and we're working to reintroduce it this year shortly. It would grow and improve the palliative and hospice care workforce by supporting the full pipeline of physician training in this subspecialty, including through academic career awards and fellowships for providers. I'm going to start with a question for Dr. Skorton. How can we better address the need for programs that train health professionals, and how does the idea of training the trainer support our healthcare workforce overall?
First of all, Senator, we want to thank you, appreciate your leadership on working to authorize these new Title VII programs to train future physicians in palliative and hospice care. It's incredibly important. And these Title VII type programs, including geriatric and mental and behavioral health, have a long-standing history in training health professionals to treat our most vulnerable Americans. So I would take the very, very quickly mention that we're supporting an investment of $1.5 billion into Title VII and Title VIII programs, and hope that Congress will think carefully about that, not only about this issue, but many of the things that we're talking about today would develop a great boost by more funding going into HRSA programs, Title VII and Title VIII, and I think that would speak directly to your question. Thank you for the question and for your creativity in this sphere.
Thank you. Dr. Mcdougall, I will go to you. As many of the witnesses have noted, the current healthcare workforce shortages that we face today are only going to continue to grow. And research projects an impending palliative care workforce crisis over the next 20 years. In the shorter term, by 2030, we could see a ratio of only one palliative care physician for every 26,000 seriously ill patients. Part of why we urgently need to grow the palliative care workforce is to ensure that more Americans and their families have access to this type of care when they need it the most. And it is a matter of health care equity in my mind. So Dr. Mcdougall, can you speak to how support for workforce development programs and provider training works to advance health equity and help us make sure that more Americans have access to the quality care and culturally competent care that meets their needs?
Another very good question. So we know from research and data that physicians from underrepresented groups have a concordance with patients that they're caring for in the population. And we've seen where this has led to increased compliance with preventive care, even flu shots. And so that's important. And that visibility in the community, becoming a trusted messenger in the community was oh so important and continues to be during this pandemic. And in regards to palliative care, I think there's also a need for just broader public education. And I would recommend to the audience a book recently published by Dr. Dan Morheim entitled Preparing for a Better End. And he speaks to the importance of palliative care. And actually, I'll read some of this. It means a practice where a patient suffering a serious illness will have not only a medical team focusing on a cure, but also a team focusing on symptoms, pain, and quality of life. And many people don't know the difference between hospice care and palliative care. So I thank you so much for lifting this important topic up, because more discussion and education is needed, especially in the community.
Thank you. Mr. Chairman, I yield back.
Thank you, Senator Baldwin. Senator Braun.
Thank you, Mr. Chairman. Healthcare has been the thing I've been most interested in since I've been here in the Senate and trying to reform it from the top down. I think it's evolved into I don't like to even call it free enterprise, because there's so many things that bother me about it. It's gotten increasingly concentrated with large corporations. You've got a urban-rural divide. I'm from Indiana. A lot of our rural hospitals are in peril. Sometimes they have to end up getting bought by a urban chain, and then it seems like it gets even worse. So in running a business for 37 years before I got here, you've got to have transparency, competition. Things have got to work well. I harp on that all the time. Here, I'd love to hear your comments, Dr. Herbert and Dr. Skorton, about on the workforce side of it. I've got a healthcare advisory group that meets 3 times a year. Doctors and nurses are kind of tiring of the profession almost, because it used to be they had a family practice or they had a viable rural hospital to work for. Now it's working for a huge corporation that seems to have a disproportionate amount of wealth, won't accept transparency and competition. The insurance companies are along with them. They tell me that has a lot to do with why we're having trouble getting nurses or even doctors when they'd want to farm their own hospital, can't do it due to the big guys having regulations in place. How much of the nature of the industry evolving the way it has do you think has to play into the lack of people wanting to get into the profession when it's some of the highest paid, jobs you can have out there?
Yeah, nobody wants to jump in first on this one, but it's a very, very important point that you make. And I would say that right now is a great time to rethink all of these disincentives. We have an increasing interest in going to medical school across the country. A lot more people want to go to medical school. Perhaps the work of those who were on the front lines in COVID had a little bit to do with that. Who knows? Whatever it is, it's a very positive trend. There's a lot of enthusiasm, young people who want to go out there and do the right thing. Leaders like my fellow panelists today who are showing the right way to point to specific areas that need to be done. So I think there's a great wave of optimism and desire to do things in the public interest. And so through your wisdom and consultation with us, we think in the private sector as well, as Dr. Herbert mentioned, we need to talk over these specific areas that are disincentives and see how we can focus on those specific areas. Throwing the whole system out, while it might be tempting in some ways, would be chaotic in a country as large as ours. But through your wisdom and our experience, I think we could work together to find those areas that cause disincentives for the profession in general. And we'd be glad offline to talk with you and your staff about that if it would be of interest. Over to you, Dr. Herbert.
Thank you. This is a big problem, and I don't pretend to have all the answers. I will mention a couple of things. The payment structure issue that we just mentioned creates incentives for doing certain kinds of procedures that is not as well aligned. I think that's part of the burnout issue. I mentioned before that there are actually compelling data that the interprofessional training model can actually reduce provider burnout. The other thing I would say is with some of these rural hospitals is that we need to help them develop GME so that they can become teaching hospitals. There are many rural hospitals out there that would like to do that. The problem is the investment, the upfront cost to develop a GME program in a so-called virgin hospital that's never had GME. The price tag just to begin the process, to get it through ACGME, the accreditation body, is between $1.5 and $3.5 million. And that's not taking into account the first few years of having a residency program when the CMS payments aren't going to be as high as they will be once it's at full steam. So it may not sound like a lot of money in the grand scheme of things, but if you're a small rural hospital, $3 million is a lot of money. But that small investment could be just enough to develop a GME program, to develop a new residency program. Suddenly now there's new energy. It brings a cultural change in many positive ways to these hospitals. So there's a way that I think the federal government could help substantially just getting us over that hump. We're partnering right now with a hospital in Maine trying to do exactly this. But, $3 million is a lot of money. So
Thank you for that. And I think for this to really be solved holistically, before we'd get more government involved with it, the industry has obviously in itself evolved in a way that I don't think is good. Transparency, transparency, transparency. Let the consumer see things, get the hidden veil that insurance companies and especially hospitals have out there that frustrate nurses, doctors, and especially stakeholders like myself, where I've wrestled with it in my own business prior to coming here. It does work. When you do those things, engage your healthcare employee and make them into a consumer, a lot of these other things start to fall in place. Thank you.
Senator Kane.
Thank you, Mr. Chair, and Senator Collins. What a wonderful hearing. Dr. Skorton, the AAMC did a report that came out last June, I believe, that predicted a shortage of 139,000 physicians by 2033. A report dated June of 2020 was probably done a few months before and probably didn't even take into account the pandemic effect. I understand you're looking at an update of that report. My prediction before I read the update is that number will not have decreased because a pandemic that's now infected more than 30 million Americans with COVID, and 10 to 20% are claiming to have long-term effects after COVID. I'm one of those 10 to 20%. And then there's been a mental health impact of COVID, which has also been significant, very significant. I doubt that the number that the shortage is going to go down. Recruiting people in is important. You've addressed strategies on that. I really want to focus on keeping people in the profession once they're in. Dr. Skorton, I appreciate your testimony today, focusing on the Lorna Breen Act that I've introduced with Dr. Cassidy and other colleagues. The problem of Keeping our healers healthy, the mental health, the frontline health providers is so important. Lorna Breen was a New York emergency room physician with family in Virginia who died by suicide in April in the early days of the pandemic as she was, just facing an onslaught of sickness and death, and then got COVID herself, and then tried to get back to work, but was worried about seeking mental health counseling because she felt like there would be a stigma. She might lose her license. She might lose her ability to practice. We have to do things to break down any stigma about seeking mental health training among our professionals, and we have to come up with novel strategies so that we can keep our healers healthy. I've even, Mr. Chair, started to rankle when I hear people talking about our healthcare workers as heroes, because sometimes heroes are people we put up on a pedestal, and that might make it even harder for somebody to seek help. They're healers. That's a good enough word, and we got to keep our healers healthy. Our Chair Murray has noted the Lorna Breen Act for action in our next committee markup. It's very widely supported on both sides of the aisle, and I hope my colleagues will join me in doing something really important for the health care of our healers. A mental health issue I want to ask each of you about is this. As we're talking about shortage of healthcare workers, let's talk about mental health workers. The National Council of Behavioral Health reported, also in a 2020 report that was done before COVID, that 77% of the counties in the United States are experiencing a severe shortage of mental health providers. The Virginia Healthcare Foundation indicates that much of Virginia is essentially a mental health professional desert, a shortage area. And these were before COVID. And so the after effects of COVID, people having lost loved ones, people having lost income, lost their jobs, seen so much suffering, these mental health needs aren't going down. Many in Virginia who were participating in substance use, group therapy sessions, or other modes of treatment to try to deal with substance use issues saw those treatments become more difficult. Zoom sessions aren't as good as in-person sessions, et cetera. And so if we had a 77% shortage of mental health providers pre-COVID, or 77% of counties were sort of short of mental health providers pre-COVID, it's going to be more after COVID. What can we do to make sure that the nation has the mental health workforce that we need? And I'd offer that to any of the witnesses.
So first of all, let me thank you for the Lorna Breen Act. It's very important. She was at Allen Hospital, rest in peace, which is part of the New York Presbyterian world where I practiced, saw patients, and taught up to about 2 years ago. So we very much appreciate what you've done. And in terms of long COVID, we're working on research to understand what's going on. Please stay tuned and stay of good cheer, because we're going to figure this out like we figured everything else about COVID. This mental health issue is dramatic and getting worse. There's no question about it. I thank two members of the subcommittee who have developed the Opioid Workforce Act, which is incredibly important, because as the ranking member mentioned, and thank you, Senator Hassan, for that as well, we are really suffering with all of those things related to substance abuse throughout America, urban, rural areas, you name it. But to focus specifically on stigma, which is probably the biggest single issue, I'm afraid to say that healthcare workers, like many other people, are afraid to come forward and say, I need help. Very afraid to do that. Afraid for the stigma, afraid perhaps even to be limited in their practice prerogatives. And this is something the profession itself really has to work on. This is not something we can unload on Congress. We have to develop ways to reduce that stigma and to make sure that coming forward doesn't result in something that will limit someone's professional choices. And I've had some experience with that, friends and personally, and would be glad to talk to you offline. But we thank you for the Lorna Breen Act. Hope that comes to completion and that we can do all of these things together, and the Opioid Workforce Act. Those things, I believe, would come together, both the providers and to reduce stigma. Thank you for all you're doing.
I yield back, Mr. Chair. Thank you.
Thank you. Senator Hassan.
Well, I want to thank the chair and ranking member for holding this hearing, and to all of the panelists, thank you for being here. Thank you for your work. I want to start with a question to Dr. Mcdougall. I've heard heartbreaking first-hand accounts from K through 12 students in New Hampshire about their own struggles with mental health during the pandemic, or their worries about their friends. Maybe the silver lining here, to follow up on what Dr. Skorton was just saying, is that last week in a meeting with them in person, I was tiptoeing around the issue. I wasn't sure fifth graders and high school students would want to talk to me about mental health. They had no inhibitions about talking to me about mental health. They are worried about it for themselves, for their friends, and the pandemic has really obviously exacerbated it. In 2020, mental health-related emergency department visits for children increased dramatically. And we know because of the pandemic, it's been harder for them to get in to see their primary care docs or to get to school in person to have the kind of mental health supports that school might provide. So we have to do better for our kids. Dr. Mcdougall, what steps can Congress take to ensure that pediatricians and primary care providers are prepared to respond to the pediatric mental health crisis we are experiencing as a result of the pandemic? And what can we do in Congress to improve access to mental health services for kids through their communities, including their schools?
Very good question. As primary care physicians, we many times are the first persons who are talked to about the mental health concerns, and in some cases we're able to manage the mental health concerns. That being said, typically it may involve referral to a psychologist or a licensed social worker to work in concert with us. And someone mentioned earlier about the importance of telehealth.
Yep.
Congress has to continue funding of telehealth. That has to continue. And we need to also prioritize training of licensed social workers, psychologists, and psychiatrists. So a strong message needs to be sent to our medical schools, our health profession schools, that this is a national crisis that we all need to step up to. So those are my initial thoughts.
Thank you very much for those initial thoughts. They're great ones. I'm just going to comment quickly that I thank all of the panelists for the support that you've all expressed for boosting the behavioral workforce and the workforce to treat substance use disorder. And I'm pleased and honored to work with Senator Collins on the Opioid Workforce Act, and we'll continue to push that through. Dr. Herbert, under the American Rescue Plan, Congress increased federal funding for home and community-based services to help more people access the care they need in the settings that best suits their needs. But this funding increase is temporary. Congress needs to make long-term sustainable investments in the home health and community-based workforce. That's going to ensure access to quality, comprehensive health services for older adults and individuals with disabilities who choose to remain in their homes. Doctor, can you speak to the role that home health workers play in improving care for older adults and individuals with disabilities, and how will additional sustained investments in home and community-based health workers strengthen our healthcare system?
So I think you nailed it. We need additional funding to support it. It's absolutely critical, the home healthcare workforce, in terms of maintaining the health, especially of our older populations. And I would simply support your assertion that the funding needs to continue post-COVID. Could I add something about
Sure.
behavioral health, since you brought that up? I mean, as a clinical psychologist by training, I could go on for hours on this topic, but I'll try to just keep it very brief. It's absolutely critical that we train more behavioral health professionals. There's no question, at all levels, not just doctoral level trained people, but master's level counselors, social workers. At the same time, what we also need to do is and this gets back to that interprofessional model I was talking about, we need to train all healthcare professionals, including dentists, to recognize, and OBGYNs, for example, to recognize and diagnose behavioral health problems. And there are behavioral health interventions that those non-expert providers can also learn to provide. And also I would add that we've made tremendous progress over the past 30 years in non-pharmacological treatments that in many cases have longer lasting effects, but they're still not widely practiced, because it's much easier to just give somebody a pill. And I'm not suggesting there aren't appropriate places for pharmacological intervention.
Sure. No, I understand that. I appreciate that. And I realize I'm out of time. I'm just going to say I'm going to submit a question for the record. to the panel because, Mr. Chair, one of the things I think we really also need to focus on is a partnership between our primary care docs and community health workers to help address the social determinants of health. Because it's so critical if docs are treating, can actually get the nutrition assistance or housing that they need. That can be a big step forward too. Thank you.
Thank you. Senator Rosen.
Well, thank you, Chairman Sanders. Ranking Member Collins, really appreciate this hearing. It is just so important, and the witnesses for your work, your compassion and caring, really appreciate that. And, you know, the entire state of Nevada has shortages of healthcare providers. It's especially true for our rural areas. Of course, rural areas probably across this country. We desperately need more doctors and nurses. We have to support our existing medical providers who choose to care for those patients in rural and underserved areas so that they stay in those communities. And one of the things my office has heard from Nevada primary care physicians that they could use more support from specialists to meet the needs of their patients. It's why I introduced the bipartisan Improving Access to Healthcare in Rural and Underserved Areas with Senator Murkowski. It's going to provide additional support for primary care providers and community health centers or rural health clinics through specialist support and accredited continuing medical education. So Ms. Spires is the leader of a large community health center. Could you please speak a little bit about the challenges that patients have accessing the center, specialty care, and how having the option for concurrent visits with both a primary care and a specialist might really improve those patient outcomes that, of course, we all want, and what kind of federal support would you like to see going forward to potentiate positive outcomes for patients? That's what we all want, right?
Absolutely. I would certainly be glad to address that. So as far as being in a community health center and access available to our patients, we do have the barrier of resources, subspecialties, if you will. One of the things that we've tried to do is integrate interdisciplinary teams into our organization as much as possible. So we have included in that pediatry, optometry, and some of those things that, in particular, thinking about a diabetic population, when you look at them and you start looking at foot exams and retinal exams and things like that, that's indicative of the holistic care of that diabetic patient. But one of the things we also struggle with is when you're looking at endocrinology, which is kind of connected with that as well, and having limited resources. And so we continue to face that challenge. And transportation is an issue, as we all know as well. So when I have remote areas such as 40 miles away, it's how do we get those patients in to be seen? And I think funding that would support some opportunity for collaboration and partnerships with some of the subspecialties, if you will. One of the things that we've done is actually we've collaborated with our local hospital to see with some of their specialties that they have hired, how do we take our mobile units on the road and go to some of these rural areas, and I do primary care and then they handle specialty care, just so that we can continue to control cost. Because if we can get out there and see them, when you're looking at the issue of finances available, then that's going to ultimately save the tax dollars money as well. And so we're continuing to work on that. But I think one suggestion would be is to continue to have insight conversations with those individuals and organizations that do have good partnerships and relationships, and deciding how can we address this issue. But I would love to see that happen. That would be great for our patients.
Well, thank you. I appreciate what you're doing. And I'll tell you, I'm also so proud, of course, Dr. Skorton, UNLV graduated its very first medical school class. 95% of the graduates were from Nevada, 26% first generation college students. We passed bipartisan legislation to support 1,000 new Medicare funded graduate medical education residency positions, of course. Really important because we've got to address the workforce shortage so we can use things like mobile units, collaborative care, comprehensive care. And so we have to work on these GME slots, especially maybe redistributing some of those unused slots. So Dr. Skorton, in the short time I have left, even though we did increase the GME slots by 1,000, some of them aren't always matched. And so there still will be qualified medical school graduates. And how can we utilize these while they may be perhaps on a gap year waiting for a residency, and to potentiate some of our rural and underserved areas? What options do you think we might use?
Well, first I want to tell you that I had the honor of giving the commencement speech at UNLV. It was recorded about 2 weeks ago to congratulate them on their first class, as well as UNR. And they're doing a lot of very, very interesting, important things. The idea of volunteerism and other things that people can do while they're awaiting the next step in their careers is one that our medical schools themselves are working on. And by the way, in the state of Nevada, both in Reno and in Las Vegas, there's a lot of very innovative things happening to connect the medical school itself with the community. I'd like to get back with you offline, Senator, with some ideas about that business of the gap year. There are some of our schools in other states that are also thinking about that. And if it's acceptable, I'd like to get back to you on that.
I would love to have that conversation because we have such a shortage of medical resources across the spectrum and across the country. We have to do everything we can to promote, protect, and enhance our collaborative models for patient care. So I look forward to that. My time has expired. Thank you.
Thank you, Senator Rosen. Let me conclude by thanking all of the senators for their questioning. I perceive that there really is a general consensus. We may not agree on every detail, but I think there's a general understanding that we've got a crisis. I think we have a pretty good understanding of where we want to go and have to go. This is a solvable problem. I mean, this is the wealthiest country on earth. Yes, we can have enough doctors, and we can have doctors and nurses in the places that we need them. I think we can do this. And I think the Congress and the medical profession have got to be working together on this. So I just look forward to working with my colleagues here, and I want to thank the panelists for their great testimony, Senator Collins for her help on this. And I would ask unanimous consent to put into the record letters from 9 different healthcare organizations who are interested in this issue. Okay, well, thank you all very much. This is, I think, a great hearing, and let's go forward together on this. Thank you all.